Right. Hi, everyone. This is Dr. Funke Afolabi-Brown, the founder of the Restful Sleep Place and Restful Sleep MD. And our mission is to make sleep a thing so that you can thrive and reach your fullest potential. I have an incredible guest today. In fact, let me tell you what we were talking about just before we jumped on. But before we do that, actually, let me introduce Dr. Caissa Troutman, who is phenomenal
Oh,
brilliance.
thank
She
you.
is not double, not triple, but quadruple board certified. This woman knows her stuff. So if you're joining us live, I want you to hit live. If you're on the replay, let us know as well. And we're really going to be talking about a very fun, but maybe not so fun topic, which is sleep and menopause. So good to have you, Dr. Troutman.
Oh, thank you so much for having me. It's a pleasure. I'm so excited for our talk. It's gonna be so much
Yes,
fun.
yes, it will. So, maybe start by introducing yourself. I'm like so excited. I want to jump in, but I think we'll start with that.
Sure. Yeah. So again, I'm Dr. Caissa Troutman. I'm the physician founder of Midlife Remedy and Weight Remedy. I have a direct care practice in Camp Hill, Pennsylvania, and I focus really on two things. One is to help make weight loss the make help make the weight loss journey easier by really combining nutrition, physical activity, mindset, sleep, stress management, and prescribing FDA approved medications for weight. And my second passion is helping women going through perimenopause and menopause thrive in midlife using FDA approved hormone therapy in the form of estrogen, progesterone, and testosterone. And I love it.
I know, and I have seen your work. You are passionate about this stuff, which is incredible. This is so important. So it was funny. I was going to mention just as we were about to jump on and hit live, one of the things I said is, I have all these questions and you have to answer them in 30 minutes
Right.
because my women are tired. Many of the women that I work with have ADHD. And you said something so profound. So I
Yeah.
want us to start with that. I said, oh, yeah, most of my women have ADD, ADHD. And you said, well, is it ADHD though? Or is it menopause? And I'm like, oh,
Yeah.
yes. That is
Yeah. So
so,
what's
so
so
true.
absolutely. So
Mhm.
what's so interesting and I mean, first of all, maybe let's make some definitions, right? So menopause is 12 months after the last menstrual cycle. What's so kind of funky about this diagnosis or this clinical diagnosis is that it's so centered on menstrual cycles, and which real the reality is symptoms of perimenopause and menopause starts way before the menstrual irregularities. One of the symptoms that a lot of my patients experience is attention deficit or concentration deficit. I cannot tell you how many women I have. I can give you examples. I have a patient that has it truly has ADHD because she was maintained on medication since age 20. But when she was like in her late 30s, early 40s, it's like the medicine was not working anymore, you know? And I said, well, certainly it could be worsening of the ADHD, but I wonder if it's because she had other symptoms that clue us in. So I said, I wonder if if this is perimenopause. And I started her on hormone therapy. And when I saw her for follow up a month later, she said, "Oh my god, like my concentration is so much better." Now, again,
Mm.
that doesn't mean you stop the if they have a known diagnosis, that doesn't mean you stop the medication, but it just goes to show that it does affect more than menstrual cycles, So yeah.
Mm. So, I mean, so profound. So, if you're wondering about what else could it be when it's not adding up, I think it's just an important question to ask to say, okay, could this be perimenopause? So, yeah. So, thank you for highlighting that because I think that was so like to me. I'm like, oh, yeah.
Yeah.
So, let's talk about the differences peri and then menopause. Maybe
Great.
tell us a little bit about that as well as the typical symptoms that people start to see.
Love it. Yeah, I love. Let's start with that. So, how I always describe it is menopause is when you don't have your periods anymore and you have symptoms. And perimenopause is you have all the symptoms of menopause, plus you're still getting the bonus of your menstrual cycle. So honestly, again, it's very focused on that menstrual irregularities. So the average age of menopause in US adults is 52.
Mm.
The average age of perimenopause is 47, but symptoms of perimenopause can start as early as 35. And how I
Mm.
really like help my patients understand what are the symptoms, because we all know hot flashes, right? We all know menstrual changes, but if we kind of take a second and just remove the idea that it's just sex hormones and think
Mm,
of them as hormones, right? So
mm,
what are hormones? Hormones are basically a signal that comes from one cell, in this case the ovary, and the hormones travel throughout our entire bloodstream, and anywhere that there's a receptor, that hormone will work there. So in women, estradiol or estrogen has a very high concentration of receptors in our brain. So if you have 20 years that your brain was getting estrogen, which is, directing a lot of how our neurons work, how our brain works, how our thermoregulation works, mention hot flashes, how our mood, anxiety, depression works,
mm,
how our sleep works. So it was exposed to that for so many years. And then come perimenopause, we have the dips, the highs, the dips, highs. So that is kind of really where the symptoms start to manifest in patients as
mm.
early as 35.
Wow.
I mean,
35, y'all.
yeah. I mean,
Mm-hmm.
I always start really with my story too. Like I didn't know I was in perimenopause until later on. Like as I look at my own life, when I have the lens of what I know now with hormones, I'm like, oh my God, I was probably in perimenopause in my late 30s. But I didn't know because as women, we're just, we're so used to being stressed. We're so used
Yep.
to just pushing it off. We're so
Mm-hmm.
used to quote unquote dealing with it, right?
Mm-hmm.
and
Yep.
and to
Yep.
to so it's such, I think that's one of my missions really, is like just educating people, like, yeah, you could be in perimenopause, and hey, there's so many things you can do now, like improving your sleep, like cognitive
Mm,
behavioral therapy, which I know is what you do specifically, and a lot of the things that you can do to help, so that when you get there, will lifestyle changes, can lifestyle changes alone help? Absolutely. But for some women, hormone therapy, and I would like to say that for majority of women, I would say
mm.
hormone therapy may be very helpful in alleviating symptoms.
So let's talk. You mentioned it. So let's talk through the common sleep symptoms that women in perimenopause and menopause may present with.
Yeah. So insomnia, and typically, and you probably know this more than I do, but there's the initiation insomnia and maintenance insomnia. What's
Mhm.
interesting in perimenopause is it's the maintenance insomnia, which is more prevalent, which is more common. And that would be you go to bed fine, and then at 2 or 3 a.m. you wake up and you stare at the ceiling and you can't freaking go back to sleep, right? I mean, anybody raise up hands, because that was me.
Mm,
And you try your best, but you can't go back to sleep, right? Then definitely there are treatment options for that, right? CBTI, etc., which I'm sure we can kind of talk about, and is your specialty. But that is like a classic symptom, and what's interesting is it is actually that is more common, the trouble falling asleep, although of course some patients actually have the trouble falling asleep part.
yeah, yeah. And I think it's probably, and I talk about this a lot too. The reason why you probably are able to fall asleep okay is because you're so
Tired.
exhausted. You're so tired.
Mm-hmm.
And so you're able to get that initial crash the first third of the night, and then now the wake up and it's hard for you to, because your sleep drive is down. So I think that's really important. What other symptoms do you tend to see people present with?
Yeah, so first of all, when we talk about perimenopause
Mm,
symptoms, the way I would kind of look at it is like, okay, which can be affected by estrogen, which can be
mm,
affected by progesterone, which can be affected by testosterone.
mm,
And the way I kind of would classify it, estrogen, the low estrogen symptoms are the hot and dry, so not hot flashes is a very common example, but includes dry skin, um, you know, the hair issues, the vaginal dryness causing pain with sex and decreased, and hence causing intimacy concerns in a relationship. When it comes to progesterone, it's the anxious and insomnia is very common, and that really matches with how we normally see progesterone. So interestingly enough, progesterone actually starts to trend down earlier that in women. So around 30s, we start to see that
mm,
trend down of progesterone, um, which is why it's more common in perimenopause, because that's
mm,
the more predominant issue. I describe progesterone as nature's Xanax. It's very calming. It
Mm-hmm.
works in the brain, specifically what we call the GABAergic pathway, which is that kind of calming turn off switch in our brain, which then can help with if patients suffer from that anxiety slash
Mm.
trouble sleeping. And as you know, right, sleep is so multifaceted. It can be affected
Yeah.
by so many things. If they're
Mm-hmm.
anxious, they're not.
Yep.
It's going to be hard for them to either initiate sleep or maintain sleep.
Maintain. Mm-hmm.
Mhm.
Mm-hmm. That's good. I love how you've split that up. The role that progesterone plays and the role that estrogen plays in sleep. So tell us a little bit, because another thing we see around menopause and perimenopause is weight gain issues. So how is that? And maybe we can weave in how sleep plays a role in all of that too.
Yeah. So I mean, I'd probably quantify it by saying, again, weight is multifactorial, right? I mean, the
Mm,
old message is calorie in, calorie out.
yeah.
Now we know that that old science doesn't really correspond to what we are truly seeing.
Yeah.
So now, what I call modern science is we really look at it not just from nutrition and exercise, which is very important. And that's part of what
Yeah.
we talk about, right? But
Mm-hmm.
we look at genetics, epigenetics, meaning what we were born with, what we were exposed to. We look at stress, we look at sleep. So all of these are factors that affect our weight. Um, so and in perimenopause or menopause, the major thing that happens there is we lose estrogen, right? So when we lose the protective effect of estrogen, lots of things happen, not just with anxiety and sleep and hot flashes. Actually, our cholesterol goes up, so it affects our heart health. Without you changing anything, cholesterol goes up, the LDL or bad cholesterol goes up. It also affects something called insulin resistance. So that's
Mm,
why women now, without changing anything, they're now noticing fat deposition in what we call the visceral fat, which is in the belly, which nobody likes that, right?
belly fat.
Yes, yes. And when you have that insulin resistance, that's when the body is getting the signal to store as opposed to utilizing energy. So so low estrogen or decreasing estrogen increases insulin resistance, which then increases that storage of the storage signal that our body gets. And then again, there's a cascade that happens from that. But the other thing that happens, so it's insulin resistance, number one. Number two is the other thing that happens is we also lose lean body mass.
Mm,
That's predominantly due to aging.
mm,
But again, for the most part too, we are also more sedentary, right?
yes.
We as women, I see this all the time. Like we take care of everybody else first and us last.
Yeah.
So I'm sure the
Mm,
moms that you take care of, I mean, so common. So a lot of the times when I start to see patients in my practice, the one of the first things they say is, I'm taking care of myself this time, which is so true. You have to take care. You cannot pour from an empty cup, right? So if you're depleted, it's not going to happen. And
yeah.
lastly is sleep, right? Hot
Mm,
flashes, anxiety, the fluctuations of hormones can predispose or make us more likely to have trouble sleep. And as you know, when we don't sleep, cortisol goes up. And then when you have
yeah.
that increased cortisol, the body's like, oh my God, what's happening? And it does not, it kind of sends that signal of storage again. So
Mm,
yeah.
mm-hmm,
Yeah.
mm-hmm. Yeah. I love that. I love that. Now, talk us through what to do, right? We've talked about just how, I mean, these changes are pretty dramatic, right? And I think the work you do is so powerful. You're empowering women to not feel like, oh my goodness, the dreaded menopause. It could be it doesn't have to be that time where you dread, because now there's so many options available. So maybe we'll start off with just the general type of tips and strategies you give from a lifestyle standpoint for women who are going through this that may potentially, of course, impact their sleep in a positive way. And then we could talk about what medications and things like that are available.
Yeah. So I think the first thing I would definitely recommend is just talk about it. Talk about it
Mm,
with your girlfriends, talk about
mm,
it during your girls' weekend party, because the more we talk about it, the more we realize that our friends are probably struggling through the same thing, and we feel
Mhm.
less alone, right? Again, it's very stigmatizing. It's so hard to bring it up to your provider. So I think just being aware that you're not alone is the first thing. And in terms of in lifestyle, the way I kind of look at it too is a meals, movement, mindset, and mind. So meals, when it comes to menopause, I usually recommend high protein, high fiber, high anti-inflammatory way of eating. So your omega-3, your fish, seafood, chia seeds, high protein, of course, plant protein, animal protein, um, and then high fiber from your fruits and vegetables, your grains. If anybody's specifically looking for like a plan, like a Mediterranean diet has been shown to really impact heart health. Um, so that's a good kind of starting point.
Mhm.
Two, for movement, we usually classify it with strength training and aerobic. If women are going through perimenopause, I usually, well, first of all, I recommend doing what you can do, right? But if you have the ability to kind of choose, definitely prioritize strength training, because we just talked about how muscle mass that does start declining in our 30s. So we want to build that up, so to speak, right? So instead of like when we're in like our 40s and we have minimal muscle mass, if we start that earlier, then you have that kind of like banked in already, right?
Yeah.
um and then for the mind, a big fan of sleep. And I love my sleep. I protect my sleep. So I mean, I do everything. I'm an early bird, so my family knows, like, oh, mom's asleep now, mom's going to bed now, like, so I protect sleep at whatever cost. And really, stress management,
Yeah.
it's so important. And that's such a big word, right? Stress management there, I mean, but just mindset in that you can handle things that come your way, stress
Yeah.
resilience, big fan of that.
Yeah.
Read a lot of books about that. Yeah.
Yeah. Yeah. No, I love that. I love so meals,
Meals
mind,
and
and
movement.
movement. I
Yeah.
love, I love, I love that so much. So let's get a little bit granular with specifically night sweats. Let's start with that, and maybe hot flashes, because again, these are I mean, the thought piece, again, just like you said over and over again, maybe that mind racing and all of that, maybe related, and we'll talk about how hormonal therapy will benefit, but cognitive behavioral therapy is phenomenal. It helps with that, really doing some work around, maybe gratitude, journaling, mindfulness, not going to bed with a busy mind. So that's usually, and that's something we've talked about again and again and again on this show. But tell me a little bit about the hot flashes, and the night sweats. What strategies do you tend to provide women, again, from a more natural, holistic standpoint? Because sometimes we want them to try that first and then see how things go and then realize, okay, we're going to need a little bit more help.
Yeah. So, first comment is actually the insomnia, the sleep arousals
Mm,
happen outside of night hot flashes. So that's
yes.
the first thing. So even though
Yes.
they're not having hot flashes, they could have the sleep struggles to begin with. I always want to like, kind of explain that to my
Separate
patients.
that.
Yep.
Mhm.
But yeah, I think there's several kind of sleep and hygiene or environmental things that they can work on, like dressing in layers, setting the temperature at a certain thermostat so it's cooler. Um, for some patients, so frankly, in my practice, I do go straight to hormone therapy,
Mm,
because to me it is, if they're struggling, that's why they're coming to me, because I am
yeah.
very specialized. Like, they come to
Mhm.
me because they want it.
They've
But
done all the other things. Mhm.
right. So and a lot of times patients would have tried other over-the-counter supplements. Now, Menopause Society came out with, which is, the premier menopause board, premier organization of menopause specialists, did come out with a statement, or what do you call it? An article journal, where we talk about the non-hormonal treatment of hot flashes.
Yeah.
And there are definitely there's medication specifically for hot flashes. It's not something that's kind of like my last resort, so to speak, because
Mm,
I focus more on hormone therapy.
mhm.
Um, Did I answer your question?
Yes, absolutely. Another question I get frequently is supplements. Like you said, are there certain supplements? What does the Menopause Society say? And of course, by the time they're getting to you, they probably used all the supplements in the supplement aisle.
Yeah.
But what do you see? Like when you're taking that history, what are they saying? Oh, yes, I've tried XYZ. Maybe this helped a little bit or whatever. I would love to hear your thoughts on
Yeah.
that.
So I mean, couple of things. I have I would say a love-hate relationship with supplements. I believe in them, but as you know, right,
Yeah,
it's not a
no.
regulated industry.
Hmm.
So them saying it's 10 milligrams of XYZ, it doesn't mean you're going to get 10 milligrams of XYZ.
Exactly.
Um, for what was I going to say? Menopause Society did come out with a statement that for most of the supplements, it's not evidence based to help, but
Hmm.
if it does help, go right. Like black cohosh is one that's the most
Yeah.
popular one.
Hmm.
Um, but again, when they've done studies, it's like 50-50. Some people get
Yeah.
relief, some people don't.
Hmm.
You just have to kind of monitor there's some kind of liver, make sure liver function is normal. But yeah, so and again, there's so many kind of sham snake oil stuff online. And so I usually if they come to see me by that time,
Yeah, of
we go
course.
for the hormone therapy. Which again, if you think about it, right, hormone therapy is I prescribe FDA approved bioidentical hormone therapy.
Hmm.
Which is pretty much biochemically the same as what our body normally produces. So it's very
Hmm.
biochemically similar, structurally similar.
Hmm. Hmm. So a lot of people have, as you can imagine, resistance for to hormone therapy. They're nervous.
Yeah.
It's hormones. What if I'll get cancer? Can you bust some myths and just provide some reassurance and maybe just walk us through what various types of hormone therapies there are out there?
Absolutely. And this is like one of my favorite topics. And I think the big scare, so stem from this study back in 2002 called the Women's Health Initiative. This was a big study, and they prematurely came out with a conclusion that hormone therapy, estrogen specifically, caused breast cancer and increased risk of heart disease and stroke, which we know when they looked at that data, the same data, and they kind of like weeded out the ages of the women in that study. It is, if the women started hormone therapy within 10 years of menopause, the benefits far outweigh the risks. This is a statement made by American Heart Association, American College of OBGYNs, and Menopause Society. So anyway, they came out with a statement that estrogen causes breast cancer, estrogen causes heart disease and stroke. When you look at the data, it is the exact opposite. Estrogen is actually protective against breast cancer, meaning women that were put on estrogen actually had less breast cancer than women that were not on hormone therapy. And then we also have data now that estrogen actually decreases risk of cardiovascular disease. So it's a total, different data that they initially said and what we know based on the same study and the same statistics that it's not. So I definitely understand the fear, right? Because what's that? You can't put the genie back in the bottle, as they say. So even providers have that same thought that, oh yeah, I'm staying away from that. But if you really look and read the data, it's not. So I will come to I mean, I would say that really for majority of women, because now we have what we call bioidentical hormone therapy and different formulations, right? So back then, 20 years ago, I mean, come on, 20 years, what cell phone came from like this big to this big. Like there's so many things that have changed in 20 years, right? And that includes the available formulations for hormone therapy. Now we have what we call transdermal, vaginal, versus before it was the oral version, and it was a synthetic version before. So it's a completely different, I would say, ball game at this point. Yeah.
Thank you for highlighting that. I think that's just so helpful. How about the various formulations that, you know, people that's available?
Yeah. So FDA approved medications come as bioidentical, which is estradiol for estrogen and prometrium for progesterone. They come as, or for estrogen, it can come as oral, so pill, transdermal, which is through the skin, and even the transdermal, there's different options. There's a daily option, there's a once a week, there's a bi-weekly, and then there's actually also systemic vaginal ring. And then there's also what we call local therapy, which is just in the affects the tissue that it's surrounded. So that would be the vaginal estrogen that's available. So when we say hormone therapy, we typically mean estrogen and progesterone, but actually, testosterone is technically one of the hormones that we would normally prescribe, and that is again, we use the FDA approved version of men, which we just microdose for women. Yeah, so many options, and that's what I know of a lot of women. Here's how I've looked at it. Women have just been ignored for so long. Women have just been, oh, you can handle it. It's just menopause. It's a natural part of life. Just deal with it. I can't tell you how many of my patients have been told that same statement. So they would go to whoever will listen to them, and part of that is they would go to resort to compounding hormones, which I'm not against compounding. I'm just saying that I always start or prefer or default FDA approved hormone therapy. Why? Because I what, if it's 10 milligrams, it's 10 milligrams, right? So purity, the it's the same dose that's used on all the studies, right? um and sometimes that can be, anyway, the compounding of hormones can sometimes get a little tricky, and I've seen some women kind of get like given the wrong impression about hormones in general with that, you know
So what are some common side effects that you see?
from the medicines. Yeah, so
Yes.
so the one thing I would always remind my patients is what I'm giving them, let's say estrogen, is really a sprinkling of what they've seen before, right? And we really base treatment on symptoms. Symptoms are telling us whether we're going up or going down, meaning I don't expect a lot of side effects because we're giving them back what they've seen before. But the most common, for example, estrogen, it's usually breast tenderness. It can affect our periods or make it a little irregular. But again, that's something that can be adjusted based on the dosage. So progesterone is the other hormone. The most common side effect is sedation, which we kind of like. So yeah.
Awesome. Great. I love this. I've become so enlightened about menopause, perimenopause, and hormone
Yeah.
replacement therapy. This is amazing. And I want to just say thank you for, I mean, I could see your passion exudes and just
Oh, thank you.
how you have enabled us to normalize this, but not just accept the status quo.
No.
There is help out there, and you've made it very accessible through your program and your practice. So tell us how people can find you, because now folks that were on the fence are jumping right in and saying, okay, I'm ready to take this on.
Yeah,
I'm ready
let's
to
get some
prioritize my health.
Yeah, so my brick and mortar practice is in Camp Hill, Pennsylvania, which is central Pennsylvania, but I see patients through telemedicine as long as you are in the state of Pennsylvania. So I would love to see anyone that's struggling with their weight, and let's make weight loss easy and improve symptoms. We do not have to suffer, right? Perimenopause, menopause is a natural life transition, but suffering is optional. You don't have to suffer. And there's treatment and there's hope. And you know, it's time for change. We cannot just deal with it. We can up level our life.
Oh, all of that. I love it. I love what you just said. Menopause, perimenopause is a life transition. You do have to embrace that. but suffering is optional. You don't have to suffer through it. So you guys have heard Dr. Troutman, she is accepting patients. So if you are ready to jump off this exhausted, chronic exhaustion, labile emotions kind of bandwagon with poor sleep kind of bandwagon, then you need to connect with her on her website. And I
ADHD.
put it right there. I know. ADHD bandwagon, and I think that's so powerful, so empowering. And of course, we're right here to support you on that journey. So if you or someone you love, you or your child, struggle with sleep issues where you're really trying to find solutions that actually work, that are beyond just a sheet of sleep hygiene tips, then you need to connect with us, the Restful Sleep Place. Our number is 215-607-8297, or visit us at therestfulsleepplace.com. Dr. Troutman, thank you so much. I feel so informed. I feel so empowered. And it's just been amazing just watching and going on this journey with you. And thank you for being such a master collaborator. I know you work with so many other clinicians, and you really have taken this education for women. You've really taken it to the next level. So really appreciate you joining us today.
Thank you for having me. So much fun. Yes.
All right, everyone. Until next time, I hope you rest well. Bye.